I'd like to introduce my colleague Leah Seamark from Somerset NHS Foundation Trust, where we both work. Leah leads on our dietetic-led gastroenterology service in the community, which was set up in 2012 and is recognised by NICE as a shared learning example back in 2015 and has won several awards. Leah has contributed towards the BDA-IBS guidelines and absolutely leads on the collection of all our amazing and very vital outcome data in our clinic, which has culminated in her actually publishing a paper this year on long-term symptom severity in our patients within clinic, which is a fantastic achievement, and she worked on that along with Professor Mary Hickson down in Plymouth. So I'd like to hand over to you, Leah, and all the wonderful work. She's going to talk about how our clinic was set up from the base, and hopefully that will give other people ideas of how they can do similar services. Thank you.
So I actually work with Marianne down in Somerset, and this talk was very much a joint effort, but I'll be taking you through the talk today. So down in Somerset, we have a primary care-based dietetic gastroenterology clinic, which was first commissioned back in 2012. So we're going to be talking today about our process of how we got to that point. So starting off with the concept, and then how we went about collecting data to gain some multidisciplinary support, which then led to the development of the business case. So I suppose the idea for the clinic first came in 2010, when the work which King's College London did in bringing the low FODMAP diet over to the UK and the development of their training course. So Marianne went on the very first low FODMAP training course and kind of planted the seed of the fact that there was going to be this dietetic intervention which could have quite potential benefits to patients with IBS, which at that time, that cohort of patients were quite poorly managed. And the idea then came to develop a pilot dietetic service in South Somerset. So the idea was that some GPs could refer patients to the clinic with intractable IBS, so patients who didn't respond to first-line dietary advice, and have some dietetic support, ultimately using the low FODMAP diet. Now, at that time, that was quite a novel idea, and we were really lucky to have a dietetic manager who very much said, you know what, we don't know whether it's going to work, but go ahead, give it a go, and collect some data and show me whether it's going to work or not. And that's exactly what happened. So that concept then led on to the data collection. So within that pilot service, data was collected for patients who were seen, and it was looking at symptom severity scores on a scale of 1 to 10, before receiving dietary intervention and after dietary intervention. And the results showed that 78% of patients reported a positive improvement in their symptoms following that dietetic input. Now, once you collect that data, it's going to be really important to start shouting about it, especially because at that time it was all quite new. So actually going around to those key stakeholders who were going to be fundamental to supporting your business case was really important, because ultimately that outcome data allowed you to gain support. And the first set of support needed to come from your local GPs. So these are a few of our Somerset GPs, and some of the comments we'd often get from them when we went round to talk about this dietary intervention and the potential pathway was that at the time they were frustrated over the present lack of effective treatment options for patients with IBS. And they'd often see patients some 3 to 10 times before feeling compelled to refer them to secondary care because they had no other option. So all of a sudden you're providing these GPs with an alternative route for treatment, which was shown to be effective. Now, as I said, some of those GPs were referring on to secondary care, and you may ask the question, why do we need to involve secondary care in IBS? Now, NICE and the BSG all suggest that IBS diagnosis and management should be in primary care, but at the time, IBS was often treated as a diagnosis by exclusion. And again, GPs were often referring to secondary care because they had no other option. So it was really important to then go to the secondary care gastro consultants and say, look, we've got a dietary intervention that seems to work. What are your thoughts? Now, at that time, they were finding that the secondary care referrals into the gastroenterology department were increasing, leading to increased waiting times. And they had actually been tasked at that time to try and look at trying to reducing those waiting times. So they were specifically looking at the cohort of patients who were 16 to 45 years of age with no alarm symptoms, who were basically being referred into them because they weren't being effectively managed in primary care because there was no effective treatment options. And what was happening is they were going into secondary care, having some investigations and being discharged with a diagnosis of IBS, which is great for the patient in the fact that they reassured that they've got no sinister issues, but actually in terms of that patient's quality of life, it often remained unchanged because there was no effective treatment that then followed those investigations. So what would then happen is that those patients would then come back into the service 4 or 5 years later. So you would have that revolving door effect of those patients going back and forth from GPs to gastroenterologists because they had no adequate symptom relief. Now at the time, the secondary care consultants kind of knew that was happening, but they felt it was really important to collect the data to prove that. So Emma Gregg, one of the gastro consultants at our local hospital in Taunton, did exactly that. So in May 2011, she took a snapshot of secondary care gastroenterology referrals, and she found that 14.3% of their new gastroenterology referrals were for non-red flag patients aged between 16 to 45-year-olds, where the diagnosis of IBS had already been made in primary care, but they were still referred into secondary care. And when you looked at those costs of, the appointments and the investigations, it was estimated that they were costing the team at sort of £160,000 per year. So the idea that you could actually then offer a effective dietary treatment as an alternative to that was obviously really appealing. So you've then gone from the idea of, using data, not just dietetic data, but data which was looking at secondary care impact, which then gained support of people from both primary and secondary care, and that then led to the development of the business case. Now, with the business case, we were looking at trying to fund a dietetic service. So if you're going to be asking for money to fund a service, often it's obviously quite helpful to figure out where that money is going to come from in terms of savings. So really, it was based on the fact of trying to produce savings for those non-red flag patients by offering them a successful dietary intervention. So when we look at those figures, as I said, over 160,000 was being spent for non-red flag referrals at the time. But we were put in a business case where we were asking for sort of £58,000 to provide a dietetic service, and that dietetic service was for one working time Band 6 equivalent dietitian with a little bit of administrative time, as well as some funding for fecal calprotectin. Now, at the time, fecal calprotectin, which is used to kind of screen for inflammatory bowel disease, it wasn't available in Somerset either in primary or secondary care. And the whole idea of this project was to try and keep the diagnosis and management of IBS in primary care. So it was deemed appropriate to try and include that within this business case to try and give GPs a little bit more assurance that they weren't missing something sinister before referring to the dietitian. So you're looking at a savings of over £100,000 by just from 2 district hospitals in a year. And it was these figures that kind of were put into that business case. And those figures don't include those costs associated with pre-appointment tests in the previous 6 months. And the revolving door patients. So of those 14.3% of non-red flag referrals, when they look back at their patient's history, up to 50% of those had already been seen by gastroenterologists within the last 5 years, just showing that revolving door effect of those patients. And then, like I said, GPs were seeing them 3 to 10 times before they were being referred, and then medication and prescription costs. So there's obviously potentially lots of cost savings that could be made by offering an alternative dietetic treatment. So the business case wasn't just a dietetic service. It was a dietetic service which was incorporated into a wider sort of management pathway for the diagnosis and management of IBS, which included some fecal calprotectin. And within those first few years of that service being developed, there was a lot of education going on with GPs, talking about the data and showing them how they could feel empowered to help manage that in primary care. And really, when we think about the lessons learned, the key thing was getting the right people involved from both primary and secondary care and getting their support. So it was really thanks to this multidisciplinary team, which included the consultants, it included local GPs, it included someone from the local clinical commissioning group, it included the community dietetics. And the timeline in terms of development of the business case, it was finalised in March 2012. It then went on to the Somerset Professional Executive Committee a bit later in the year and was finally approved in June 2012. So in terms of why we think this business case was successful, firstly, you've got those potential cost savings, which we discussed. You've got the support from the primary and secondary care team who were involved in the development of the whole pathway. You've got reported outcomes. So not just dietetics, but outcomes from the secondary care team in terms of the referrals. And also, it was a dietetic service within a wider business case for that pathway. And to start off with, we had the support from a manager who, at the time, like I said, we didn't know whether it was going to work, but a manager who said, you know what, let's just get on and do it and see what happens. So once you have got the business case and you've got your service up and running, we think it's really important to continue to collect that data to firstly prove what you're doing works, and secondly, hopefully provide some data to support other people develop business cases. So our gastro consultants, Emma Gregg and Steve Gore from Yeovil, then did another audit of the results of the referrals 1 year later, so 1 year after the clinic was set up. So within that year, the referrals reduced from 14.3 to 8.7% for those 16 to 45-year-olds with no alarm symptoms. And the fecal calprotectin results for the 210 patients, which were less than 50, showed that no pathology was found. So giving a little bit of reassurance to the GPs that actually the fecal calprotectin was a good indicator. And so in the first year alone, the cost for this group reduced by 25%. So those results are published in the Frontline Gastroenterology journal. So if you're looking to look at that data in a bit more detail, you can find that. The service was then also used by NICE as part of their shared learning database, as well as within their quality and productive case study. Now, and also in terms of the support that we got from GPs, like I said, within that first couple of years, we were going around sharing this data with the GPs. And in 2015, one of our GPs was saying that, having a dedicated community-based dietetic service that provides appropriate assessment, definitive diagnosis and a comprehensive treatment plan is greatly valued by GPs trying to manage these patients. And by 2016, when we did a survey of some of the senior GP partners, 96% said they had faith in the IBS diet to manage symptoms. So, if we had done that survey back in 2009, that figure would probably have been a lot lower. So, we've looked at in terms of reducing referrals, but from a dietetic point of view, it's really important, again, like I said, to collect those outcomes. So we've recently had a paper published which looked at the long-term symptom severity in people with irritable bowel syndrome. So we had this clinic set up, and we decided to do an observational service evaluation, which looked at IBS patients seen in our clinic between May 2013 and April 2017. So data was collected at 3 time points, so at their first dietetic appointment, at their final follow-up appointment as part of their kind of clinical assessment, and then an assessment was sent to them 1 year later in the post to ask them the same questions. So the results we got are very similar to what's already reported in the literature. So we found that the improvements that we saw in symptoms such as the bloating, the pain, the wind that we saw at short term were maintained in the long term. And that remained significant for all symptoms apart from heartburn and acid regurgitation. An adequate relief was reported by 66% in the short term and 55% in the long term. So I think it's really important to not underestimate the benefits of surface evaluations in real-life clinical practice. So it's great having the RCTs to kind of dig into the whys and the hows, but if we're looking at trying to produce more data to support business cases, we probably need more service evaluations of such services. And also, as part of that, we also looked at stool types, so there was improvements in the reported frequency of normal stools and increased reporting of normal stool open frequencies. Now, we also asked questions about healthcare usage. So again, if you're looking at trying to produce a business case, it's trying to show potential cost savings. So we asked patients in the year prior to dietetic input how many times they visit their GP, their gastroenterologist, and whether they'd had investigations for their gut symptoms. We then asked them a year after receiving dietary treatment the same question. And we found that there was a significant reduction in the number of patients reporting seeing their GP, their gastroenterologist, and a significant reduction in their investigations. So I know it's not an RCT, so we can't kind of determine a cause and effect, but what you're saying is you've got this cohort of patients that after receiving dietetic advice had significantly less input from both primary care and secondary care. So if you are building a case for a business case for sort of the IBS clinics, on our patient webinars website, which is where we host all our patient webinars for a range of different conditions, at the very bottom there is a section for healthcare professionals. And when you look at that, there is a link for information for NHS business cases. So have a little look there. So if you want to use any of the Somerset data to support that, all those papers are freely available on that website. And I think I just really want to highlight how important outcome data is. So that outcome data, which demonstrates the effectiveness of the diet as well as the change in referral rate, was key to having that successful business case. Now, Back in 2014, we submitted a business case for celiac disease, and actually at that time there was such a lack of data showing the potential cost savings of having dietetic input in celiac disease that actually that case was unsuccessful. And when you compare that to obviously IBS, where it's such a costly condition, where we could show that actually money could be saved. So what I would, carrying on from what Christian said earlier, it's really imperative that if you have a celiac clinic already set up, think about collecting data from the word go. And yes, ideally it would be some sort of online format where a patient fills it in online and then it all kind of nicely comes in an Excel spreadsheet for you. But if you haven't got that, a piece of paper as part of a questionnaire and an Excel spreadsheet will do the job. And it's also really helpful to collect data on all referral types, so not just IBS. Patients with IBD, late onset radiotherapy, so just to show that actually we're not just providing effective dietary treatment for IBS, that we can actually provide effective dietary treatment for a range of gastro conditions. And then from a personal point of view, ideally we want you to publish these results. And if you're going to be doing that, it's really helpful to get a stats expert at the word go to help you figure out what sort of questions to ask and also how to analyse that later on. So in summary, why do we think our business case was successful? Firstly, we had the dietetic management support. We had the multidisciplinary support from both across primary and secondary care. What I would say to you, if you're going to set up a clinic, ideally, set up a gastro clinic, not just an IBS clinic. Because if you set up a gastro clinic, then you then have the potential to incorporate other conditions into it, rather than specifically setting up a new clinic. Collect outcome data to support your business case, but if you haven't got that, try and use the published data which is already available, and try and focus on the financial benefits to GPs and secondary cares if you're going to be asking money to fund that dietetic service. And again, look at those patient outcomes. Before and after dietary interventions, what happens to those patients? Do you improve their symptoms? Do you reduce healthcare input? And publish that result so it's freely available to everyone. And that publication results could be in something like a journal, or it could be presenting at the BDA Research Symposium, it could be in one of the dietetic magazines. So just shout about those outcomes to try and support everyone within the profession to develop those business cases. And ideally, if you're looking at trying to meet demand, and it's trying to also include the digital patient engagement and the resources to try and help manage any potential demand, as well as look at patient-initiated appointments. So within our pathway, it's developed over the last few years. So this is our new sort of pathway for the IBS diagnosis and management in primary care. So there's been changes to the fecal calprotectin levels, but also within that, we've got our patient webinars, which is very much utilising that to provide first-line dietetic advice, with those which are intractable then being seen in our clinic. So thanks very much for listening.
Very good, Leah, absolutely excellent, but I would say that. But one thing I wanted to ask is, a lot of people, I think, are quite scared about collecting outcome data, not quite sure how to collect it or what ways to collect it. Are you happy to share the way you've collected your outcome data and any spreadsheets you've got and any information you can give? I mean, it's something we could put on the website, so anybody wants, we could have an outcome data section on the website. So
our outcome data was based on what was produced by King's College in London initially, with some additional questions on, but we can definitely put that on the website. And it would be great to kind of develop a nationwide set of outcomes that we can start collecting, which kind of have a dual effect. So they help inform your assessment, but also they can be used for outcome data as well.
If we could digitise that, perhaps, so that everybody could nationally use the same package, the same digital sort of patient questions, and we can just get a central place for collecting all data. We could have amazing data that could really prove dietetics.
Yeah, digitalisation of it would be amazing, rather than having to sit there and manually enter into an Excel spreadsheet all that data. So something which is digitalised, which does that all for you, which can also produce something like a PDF version of that specific patient's responses, which you can utilise as part of a patient record, would be fantastic.
And get it from all the different departments nationally, so that we've got a really strong case for proving worth of dietetics. Yeah.
Absolutely.
Excellent talk, thank you.
Thank you.
Thank you.